Good evening, everybody, and thank you very much. I have not eaten anyone's biscuits, not even my own. So there should be lots of extra biscuits out there by now for everybody. Okay, I am talking about the FemPrep clinical trial that we conducted at Suchava Research Center, and how does this impact on our approach to HIV prevention. Before I even proceed, I think I just need to give you a little bit of background about Suchava. We are located just north of Pretoria, about 30 kilometers from Pretoria, in an area called Soshanguve. And the name Soshanguve was derived from the different ethnic groups that formed the community during the apartheid years. We are situated in Block H. Soshanguve, out of interest, does not have street names. It only has blocks and numbers. So Block H is where we are situated, and the research center was developed in 2003 as a joint venture between the Medical University of South Africa, Medunsa, and Population Council. And it was developed purely for the clinical trial of Keragard that was at that time done with Population Council. Since then, we've conducted a number of trials in HIV prevention, different social science trials, vaccine trials, and drug trials. The main trials that we have been involved, or the last trials that we have been involved, was the Keragard trial, the microbicide Keragard trial that had been completed, the FemPrep clinical trial that is still ongoing for our seroconverters, and the current study that we are involved with is the proudly South African FACT study that I'm sure you all are aware of, that's going on now. A little bit of background that we're also familiar and probably tired of, but it always helps to give a little bit of emphasis on that, is that HIV has been existing from the 1980s and is still a major problem. We're having lots of deaths from HIV, and it's really become a major pandemic. We know that it's not a gay disease. We know that there's increased infection, especially in women, and this is related to the vulnerability of women through heterosexual transmission, that we do get infections in babies, and we've known about PMCT as a prevention option, and that it's associated with various conditions like STIs. So I'm not going to go too much in the background of that. In terms of preventing HIV infections, there's been a bit of ambiguity in this field, in that we've had limitations in progress because there's been a slow and insufficient response from the world. There's a lot of social factors, including stigmatization, discrimination, skepticism, and a lot of denial still. When we started talking about prevention of HIV, we went right back to the ABCs of prevention, which we all know so well. However, there's been also a lot of progress. There's been progress in the social science aspect of it, in behavioral science, in the medical science, and here we've looked at lots of data that has emerged on circumcision, prevention of mother-to-child transmission, vaccine development, microbicide developments. Lots of products have come into the pipeline, and all the clinical trials that we've conducted in all these years have actually contributed so much that we can now use this information and proceed, hopefully, to get some good prevention options and strategies in the future. So we all know the breaking news of 2010 and 2011, the vaccine breakthrough, the microbicide tenofovir gel done by the CAPRISA 004 group in Durban, KwaZulu-Natal, the oral pre-exposure prophylaxis research that has come out, and the treatment for prevention research that has come out. So this is just a slide showing up to July 2011 what has been our progress in terms of HIV prevention research. We've had a vaccine that has shown 31% effectiveness, and we've shown treatment for prevention which has a 96% effectiveness. So there's been a large percentage effectiveness across all the studies. The microbicide research was the CAPRISA 004 study, and just for information, the FACT study that has been conducted by an all South African group under Professor Helen Rees is a follow-up to prove the CAPRISA 004 results, so that hopefully we can get licensure of the product in future. STD treatment study done in Mwanza had shown a 42% effectiveness. Important with the pre-exposure oral prophylaxis was the IPREX study results that were released in 2011, which showed that the single dose of Truvada, daily dose of Truvada, could prevent up to 44% of infections in men having sex with men. The circumcision has a effectiveness of 54%. The Botswana TDF42 study done in females, in heterosexual females, showed a 63% effectiveness. And this one showed a 73%, the PrEP for discordant couples. This was a Partners for PrEP study, and I'll discuss this a little bit more as we go along. Major breakthrough is that we can treat the HIV positive individual effectively, and that will reduce the transmission to the uninfected partner. So that is major breakthrough. So if everyone can get onto treatment at the right time, hopefully we can also control the epidemic through that. Before I even go on to the FemPrep study, I think that I should actually mention the latest from the VOICE study. If any one of you is following the VOICE study, it's a 5-arm study that contained 3 oral arms, the tenofovir oral, Truvada oral, and a placebo, and a 2 gel arm study, the tenofovir once daily gel and a placebo gel. And on the 16th of September this year, the VOICE DSMB reviewed the data and recommended that the oral tenofovir arm be stopped because it would not show any effectiveness if it was allowed to progress. And this obviously came with a lot of disappointment, and a lot of questions were raised as to why the study showed these results. So, just to brief you quickly on our FemPrep study. FemPrep stands for Female Pre-Exposure Prophylaxis for HIV. It was conducted in 4 countries in Africa, and actually the Zimbabwe site that I've got, they did not even start the study because the study was halted by the DSMB before they could start enrolling the first participant. So it was conducted at 4 sites, 2 in South Africa, 1 in Kenya, and 1 in Tanzania. It was a phase 3 randomized study which was placebo controlled. It was double blinded, and it was testing a daily dose of Truvada in women to see if it could prevent them from getting HIV. So the sample size was approximated to be 3,900 women to give us 72 endpoints, and we obviously had to enroll participants or women that were HIV negative at higher risk of getting HIV infection, and the high risk was defined as women that had either multiple sexual partners or had more than 2 sexual acts per month. Then we followed, the study was designed to follow up the participants every month for 1 year on study product, and the seroconverters were then going to be followed up for a year at the time, from the time they then seroconverted. So the objective of our study was to determine both the safety and the effectiveness of a once daily dose of Truvada in preventing HIV acquisition. We had multiple secondary endpoints looking at what would the effect of Truvada be on a participant that's seroconverted. For example, would her viral load be affected? Would the CD4 count? What resistance would develop to Truvada? What sort of adherence would we get into the study? How would it interfere with their behavior and their risk compensation? And what would be the effect on pregnancy? We had a full social behavioral component to the study, which was done prior to the study, where we had a preparatory phase where we actually went into the community and discussed with the community what we intended doing. We got a community advisory board that was formed. We liaised with the community on the protocol, whether it was acceptable, what is the correct terminology, and we mapped out areas where we could recruit women that had high-risk behavior. During the study, we continued with the social behavioral research, where we looked at adherence and risk compensation. There were interviews done with trial participants, both the HIV negative participants and the participants that seroconverted, to look at various factors like adherence, retention, understanding the clinical trial, the experiences, any myths and concerns that they may have had. With the seroconverters, we actually looked at how they were coping with their seroconversion status, what did they access their care, how did they adhere to the product prior to them seroconverting. We were looking at whether adherence was optimal or not. We did a lot of community focus group discussions, and we looked at, we monitored our recruitment along the time. So the Data Safety and Monitoring Board analyzed the data up to the 18th of February 2011, at which time we had screened 3,752 women across the 4 sites that I mentioned. Women were excluded if they did not meet the criteria, and our major exclusion reason was HIV. Overall prevalence across the sites was 21%. We enrolled 1,951 of the 3,900 that we had originally planned when the study was designed. The mean age of the women in the study was 24 years. We had a 90% retention in the study, and the self-reported adherence to study product was 95%, and this was on the basis of the monthly interviews that we conducted with our participants. So every month when a participant came to the center, amongst other things that were done at her visit, we also interviewed her to ask her if she had used the product in the last month, and this reported adherence was 95%. The sexual X that the women's reported was on average about 3.6x per week. At the time when the DSMB reviewed the data, there were 56 infections that 56 new infections that we had encountered, giving us an incidence of about 5% per year. And very surprisingly, we had exactly an equal disposition between the placebo arm and the Truvada arm, 28 in each arm. Women that were in the Truvada arm experienced this mild side effects that are documented with Truvada. There was no major safety concerns. And the contraceptive use, we found that the women, 66%, we offered contraception at the site because we wanted to ensure that the women didn't fall pregnant. So every time they came to the clinic, they received their contraception. 66% of the women used injectable contraceptives, 30% used oral contraceptives, and despite this we had a 9% pregnancy rate in the clinic. And we found that the higher rate was in the Truvada arm of the participants. So obviously that is something that is a new finding for us in research and needs to be explored. So the DSMB said that if we continue the study, it would be highly unlikely that Truvada will be able to prevent HIV infection in women. And the IDMC found that the trial was conducted to a high standard, but recommended that we actually stop the trial. So the trial was closed for the HIV negative cohort in a very orderly fashion. Obviously, there was a lot of community outreach that needed to be done at the time of trial closure. Participants had to be informed of the results. They had to return their study products. We followed them up for 3 months after trial closure. And the last participant exited our center at the end of August this year. And now we are sitting at the point where we are analyzing our data because our results are surprising to us. And at this stage, we cannot say for certain whether Truvada works to prevent HIV infection in women or not. So we tried to extrapolate all the possible reasons why it did not work, or why it did not work, but why it showed what it did. The possible explanations is that we thought adherence may be too low to show effectiveness, and this is a strong possibility, even though women reported 90% adherence on a self-reported interview. Biological factors that would have caused this result, that women may have shared product, and just a little bit on that is that at our trial center we had each woman was given a bottle of a study product, and it had a unique bottle number on it. And the next month she was asked to return the bottle even though the pills should have been finished. And we then looked at the product, the unique bottle number, to see if it was the same one that she was issued. We found 3 participants in our study that had returned the incorrect bottle. So they claimed, or they informed us, that it was their friend's product that they were carrying in the bag. We don't know exactly what happened, if they really used the other product or they didn't, but obviously it does raise our eyebrows to the fact that did they share product or not. Other possibilities that it was just a purely chance finding, or it's a combination of all of the above. So a little bit more on the biological explanations, that we're taking an oral product and we're looking at levels, we're looking at transmission through the genital tract. So it's possible that there are not sufficient levels in the genital tract, and we know other studies have shown that even taking an oral product does give you sufficient levels of protection. So we are not sure. We know there's a differential distribution in the rectum and the female genital tract, and that was evident by some of the studies that had been done. We think that we may need high levels at the site of HIV entry, and that maybe a single dose may not be enough. We don't know the effect of the contraceptive hormones now, because we've seen this association with pregnancy in the participants in the Truvada arm. So we're not sure, did the contraceptive interfere with the effectiveness of Truvada or not? Or it may be side effects of the Truvada itself which led the participants not to adhere to the study product. Because they felt nauseous, they just skipped the pills. We don't know. Whether there's genital inflammation, what is the cause of this inflammation and what is its effect? Our hypothesis for the pregnancy finding is that from previous data on Truvada and contraceptive, there's no known drug interactions. However, we just don't know. There may be interactions that we still start having to explore. Or it may just be the fact that women that didn't adhere to the study product didn't adhere to their oral contraceptives as well. So if they missed the Truvada, they missed the oral contraceptive as well. Was it due to the side effects of the Truvada? If they vomited, they possibly vomit out the oral pill contraceptive as well, and that led to the ineffectiveness, or was it purely a chance? So where we are now is that we are going to be doing a lot of data analysis, and we're going to be looking at HIV, the seroconverters, looking at obviously when did they seroconvert. We're going to confirm the time. We're going to look for resistance in these women that have seroconverted. We're going to look now, important is for drug levels in the participants. At each visit, participants came and we drew blood and we stored the blood. So now we're going to look at actual evidence of adherence, to look at drug levels, and we're going to look at the contraceptive hormone levels. So our big concern came in our study results when we compared these results to the Partners for PrEP study. This and the TDF2 study, which was the Botswana study. The Partners for PrEP study showed a 73% effectiveness in people that had used Truvada as a single dose for prevention of HIV. Similar to our study, once a day dose of Truvada, they used once a day dose of Truvada, but there was such a big difference in the result. So we asked ourselves the questions as to why. What was evident, and what is really quite evident to us all, is that we are working with a different population. The Partners for PrEP study actually took discordant couples into the study. So one partner was HIV positive, one partner was HIV negative. The partners knew their status. So maybe they adhered better because they knew that their partner was HIV positive and they had to adhere strongly to the product to take the pill. Our population, a lot of the women don't even inform their partners that they are taking, they are in a clinical trial. And maybe that interfered with the adherence, of course. What is the role of sexually transmitted infections in our population compared to the Partners of PrEP study? We don't know. There's still a lot of ongoing analysis. Adherence I've mentioned, and of course underlying inflammation that can affect our HIV susceptibility. So FemPrEP was conducted by FHI 360 and PrEP by the University of Washington, and the TDF study was done by CDC. So the three organizations are getting together to look at these differences that we've received in our results. So what we do know is that we have to now identify the driving factors that may have influenced our FemPrEP population, and of course even the voice population, because the one arm, the oral arm, the tenofovir arm of the voice study was also stopped by the DSMB. So what is the driving force, or what is the driving factor that is affecting our results in this way? So the question comes, is it time for new strategies and new tools? And the answer to that is both yes and no. We have a lot of information already from trials that we've conducted. So we need to improve on that rather than just to move to new strategies. So we know that if adherence is a problem, how are we going to improve adherence? How can we make sure that women don't forget to take the product, are motivated enough to take the product? So we need to look at the different delivery tools. Now, for females that are sitting in the audience, I'm sure if you have been taking an oral contraceptive, you know that it is difficult to adhere to the regimen every day. You tend to forget, or you get lazy, or an injectable contraception is probably just much easier because it's one injection in 2 months or 3 months, and you got enough protection. So we need to look at new delivery tools. There's a lot of work been going on with gels and rings at the moment, and rings are becoming are tested currently in clinical trials because this is a once-a-month insertion into the vagina to release the microbicide into the genital tract for protection. That may work better in terms of adherence and compliance. Oral preps, we know the once daily dose for us was difficult for participants, so is there something that's even longer acting? Injectables, patches, implants, we're getting all these possibilities from oral contraceptives and adherence to contraceptives. And the MPPs, which I'll just discuss just now. We also need to look at, before we can say that a product did not work, we need to make sure that they really did adhere to the regimen. So we need to look at how to measure adherence. We know that we've used self-reported interviews, and participants often would tell you what you want to hear. So if you ask them, did you take the pill every day for the last month? And they'll say yes. They're supposed to return the study product, and they know that they're not supposed to return a bottle with more than 3 pills, because we used to give them 30 pills, and they had to have, they were followed up every 28 days. So if they have 3 pills or more, then we were going to raise questions. So they would withhold the pills when they come in return. So even pill counts are not good. The dye test we used for the microbicide, the Careguard study that we did, and again it was challenging. We could actually determine if the women inserted the applicator into her vagina, okay? Because the dye that we tested picked up vaginal mucus. So the women were asked to return the used applicators without washing them, bring it back to the clinic, and then we did the dye test. But women got clearer in the study. And so they emptied the contents of it and inserted into the vagina and brought it back. We don't know. We don't know what practices are going on out there, and women talk to each other. Okay, the Wise bag, a new concept that when you open the bag and remove an applicator, it triggers off that you've opened the bag and removed an applicator, but it tells you nothing about inserting the applicator. Okay, doesn't tell you that the applicator was inserted. So again, we need to look at those technologies on how we can actually determine if the applicator was inserted. Obviously, the most scientific way is to look at drug levels, both in the blood and in the cervicovaginal fluid. And interviews, we know, are not always reliable, but what we did in our study and a social component is that we did group interviews. So women in a group would actually share more information on adherence than on a one-to-one. Okay. So when we look at improving adherence, I mentioned the delivery tools, and I mentioned a ring versus a gel, and this is just an example of how a ring would work as compared to a gel. So if this is the concentration of the product that is required for effectiveness, once you insert the vaginal ring, there'll be a slow sustained release at that concentration all the time. And if you have A, B, and C sexual acts, you will be protected. A coitally dependent microbicide, where you insert it just at the time of your sexual act, you need to remember to do it. You need to be prepared to do it. Spontaneous sex may kill it. Okay, so you need to think about those things. New technology known as nanotechnology, mucus penetrating nanoparticles, or MPPS, is looking at a concept where microbicides are going to be formulated in tools, in nanoparticle tools so that they can be distributed evenly in the vagina, because you often have plugs of mucus in the vagina where the microbicides cannot penetrate. So this is new technology that's coming out, and looking at using microbicides and vaccines through nanotechnology is becoming quite new in the field. Okay, so I said we need to look at where we can improve from our current studies before we just go and look at new strategies. So let's look at biological factors. We need more studies on pharmacokinetics and dynamics of the drugs. Why was it that the Partners for PrEP study showed that there was protection, the IPREX study showed there was protection, but our study did not? Does it mean that our study population needs to be taken higher doses, or they need to adhere better? Important is we need to know what is the right dose of drug, what is the right drug to get, where is the right place to get it, and at what is the right time to have it there. So it's no use you having something inserted into the vagina and it's there for a week, but at the time when you're having sexual intercourse, there's no drug levels there. We need to look at the effect of contraceptives and the interactions with a lot of these drugs. We need to look at what is the underlying inflammation that, despite drug adherence, we are still getting breakthrough infection. We're looking at STIs. We have such a high prevalence of STIs in our community. That drives inflammation. Inflammation drives HIV. Okay, so we need to look at these things. Bacterial vaginosis, herpes, allergies, maybe to the condoms, douching that our community practices, all those sort of things need to be looked at. And the question we ask is that, do we require more adherence or better adherence if there's underlying inflammation that's present? Just to tell you that, I'm not going to go through the whole slide, but the Caprisa 004 study that was done on the tenofovir gel, which showed effectiveness, when they did inflammatory analysis on local analysis of the cervicovaginal fluid that they collected in the participants that seroconverted, they found that the participants that got HIV infection had higher levels of inflammation in the genital tract prior to them becoming infected as compared to those that did not become infected. So there is something that's facilitating the HIV infection. Okay, if we look at the mechanisms of sexual transmission, this is an old slide that I've taken out, and it just shows you the differences through the columnar epithelium and the stratified epithelium. And it shows you that, of course, with stratified epithelium, you need a physical break in the skin, which we see, which we know happens a lot because we've done a lot of interviews in our community, and we know that they practice a lot of dry vaginal sex. And dry sex does lead to microabrasions of the vagina, and that can promote the transmission of HIV virus across. We know that the time of infection from the genital tract into the draining lymph nodes is very short. It's within 24 to 72 hours you can get infection occurring, systemic infection occurring. Exposure of 30 minutes, within 1 to 4 hours, your HIV viruses can penetrate the local target cells of HIV, and then they can go into the draining lymph nodes. So the time to act is really very short, and we need to make sure that we have the right drug at the right place at the right time in the right dose. Of course, combination of some of these factors, that even though we may have got some adherence in our population, maybe it was suboptimal associated with the inflammation that may have been existing. We always have to think of sharing and infection with resistant isolates. Just for information, we've done a lot of resistant testing on our participants that have seroconverted, and we haven't shown any resistance yet. So the field of HIV prevention is really not a single agent that can prevent HIV. We know that you need to have different options open for different people. Some people have to use more than one option. We must never forget about the simple ABCs: abstinence and be faithful, condomizing, the male circumcision, but it's a whole package that we have to have available and that we have to offer. As some people would choose different forms of contraception, likewise for HIV prevention, people may choose different options. The current clinical trials that we are doing is focused mainly on individual intervention mechanisms, like either treatment is prevention or vaccines or microbicides or pre-exposure prophylaxis, and this is just a slide with some of those trials that are going on. But now the emphasis is needed for combinations that can provide a greater impact on HIV incidence. And so this was a slide that this was a presentation by Robin Shattock at the IAS conference in Rome, which was excellent actually, where he discussed the combined approaches of preventing HIV infection. And just a few things from his slide that from his presentation that I've extracted is that the opportunities for intervention doesn't start at the time of sexual intercourse. It can start way before, and it can continue even after infection has been acquired. But there's a whole, it's a whole intervention program that needs to exist from very early on until late in life. And we need to start considering a combination approach to intervention programs. So some of the possible biomedical prevention combinations that we're looking at is combining an oral pre-exposure prophylaxis agent with a microbicide. So the oral pre-exposure gives you the systemic concentrations, optimal systemic concentrations, and gives you a little bit of local drug levels. But the microbicide at the time of sexual intercourse would give you the bolus dose that you require. Looking at PrEP, oral and topical for women, and combining it with circumcision, which we know works, plus possibly oral PrEP for men. Treatment for prevention combined with pre-exposure prophylaxis for the HIV negative partner can be used, and a big field with vaccines plus ARV-based pre-exposure prophylaxis, whether it is in the form of microbicides or not. And with all these intervention programs, we have to make sure that we include our behavioral component to it. So one of the things that we're looking at is ARV protection combined with immunological protection, and this is a vaccine development that we're looking at. Can they be combined, and are there potential benefits if we use this as a combination? So this concept of VaxPrep, can it deliver better protection? And theoretically, yes, it can, because if you take in the pre-exposure prophylaxis, it will give you protection during the time when you are still developing your immunity to it. If you don't get complete immunity, it might reduce the infectious challenge and the primary foci of infection. You can boost your local immunity. You can cover between revaccination campaigns, and you can revaccinate as your immunity wanes. You can provide immunological coverage for intermittent adherence, where adherence is not optimal, and there's a lot more reasons that it may work. So under investigation is looking at a vaccine to be delivered in a vaginal ring form to boost the local immunity combined with a microbicide. And this is how it looks. This is your vaginal ring. This is the body of the ring. The body of the ring contains the microbicide. And in the ring, there are holes where the rod containing the vaccine GP140 is inserted. And when they did, these are not studies that have been done in human, but just future things that could be done. When they looked at the release, they found that there's been a release of the antigen across a period of time, and the release of the microbicides using 2 microbicides in this instant. Obviously, there's a lot more research that needs to be done in this field. Then the next step is, one thing is having the theory behind it, but then you've got to implement it in clinical trials to prove that it works or it doesn't work. So just one design that I've looked interesting to me is that assume that you have a pre-exposure prophylaxis, like we had the result for the Partners of PrEP study that shows that it works, or the VOICE result shows that pre-exposure prophylaxis does work. Then you're going to have to design a VAX-PrEP study. Now, you're going to have to give people, you can't use a placebo because it's no more ethical to use a placebo. So you're going to use pre-exposure prophylaxis alone in one arm, and you're going to combine it with the VAX-PrEP study population. The second arm would be the VAX-PrEP. You must know that in this, the cost of the whole study is going to change because you're going to have a lot less HIV incidences now, okay, because of the fact that you have already an intervention program that is working. You're going to be challenged in terms of your trial size, the cost, and then if you have VAX-PrEP showing effectiveness, does the vaccine, or how do you analyze this data in the looking at the PrEP results with it? So there's a lot of work that needs to be done in that. So yes, we need to look at old strategies, but we're also looking at new strategies. Can mucosal exposure to virus in the context of pre-exposure lead to an immune response? In animal studies, yes, but it still has to be tested in humans. Can microbicide delivery technology be used for vaccination? Yes, the ring formulations is what they're looking at now. Does vaginal vaccination modify mucosal immunity to HIV? It's indicated in animals, but it has to be still tested in humans. Can vaccine-induced immunity be broadened through protected exposure to prevalent virus? Tested in animals at this stage. Will VAX-PrEP provide better protection than PrEP alone? It's been currently evaluated in animal models. And can combination prevention be tested in human trials? And the answer to that is yes, provided that we continue our funding and we have continued need and drive to prevent the HIV epidemic. So there is hope in reversing the pathway of the epidemic, and it means a combination of a whole lot of different strategies together that hopefully we can bring down the incidence of HIV. And together with the treatment that we are encountering, we would have controlled our epidemic. Thank you very much.